Hello, please stop sharing. Hello, stop sharing.
Dr. Venkatesh, can you stop? Yeah,
Yeah,
correct. Very good.
that's fine. Yeah.
Yes, I am giving countdown now.
Yeah.
5, 4, 3, 2, 1. Start now.
Yeah. Hello. Good evening to everybody, and welcome to Dr. Venkatesh, and Dr. Prasanna is also joining. I think this day is very important because this is the only day we are discussing the pediatric part of the whole course, and therefore two very important subjects have been selected by stalwarts in pediatric urology. I think the feedback so far is quite good for the course. Let us not waste time on introductions anymore. I will ask Dr. Sabnis to start the program.
Yeah, thank you very much, and welcome everyone for this Eurovidya 5, the fifth year going on. And today we have topics which are actually relevant from the practical point of view, because undescended testes can come as a as a short case, and the reflux can come in the X-ray discussion. So this is very important. And we have two faculties, two senior people giving the talks. I have great pleasure in introducing and welcoming Dr. Venkatesh. I have seen him very close. He's probably the most Mr. Perfectionist of in urology, because he has everything. He gets streamlined everything. He's a senior consultant, and he started a new group of hospitals which are doing very well. And I've seen him very closely working, and how he has established all the protocols and everything as a chairman of Board of Education in USI. And therefore I'm certainly his fan. So I have great pleasure in welcoming Dr. Venkatesh. I also welcome Dr. Prasanna, who is also a very senior consultant, and he has established himself as a pediatric urology. In fact, wherever there are pediatric urology seminars, conferences, and teaching activities are happening, he's always there to share his knowledge and impart the knowledge for the benefit of students. So I'm sure the students will be benefited by both the talks. If you have any questions, please put up those questions, and let us listen to him. Over to you, Dr. Venkatesh. Please go ahead. You can unmute. Yes.
Yeah, good evening. Are you able to see the screen?
Yeah, just make full screen. That's it. Yes.
Yeah, it's okay now.
Yeah.
Yeah, perfect.
Yeah, take it.
Thank you. Thank you for that introduction, Dr. Sabnis. Today, I will talk on understanding cryptorchidism and its management. I am not going into the details of the surgical techniques that can be perhaps had at another forum. First, the terminologies. Cryptorchidism simply means hidden testis. Undescended testis is one form of cryptorchidism if it is not palpable. Cryptorchidism also can be absent testis. This absent testis may be due to agenesis or a vascular compromise due to torsion. Quite common, this is in the intranatal period of life. If it is bilateral absent testis, it is termed anorchia. The undescended testis is something that simply stops short along the normal path of descent. So you have cryptorchidism, there is anarchia, and then there is this undescended testis. Undescended testis, depending on where it has stopped short, can be cryptorchid or not so. The other terminology that can sometimes be confusing is a retractile testis. This is a normally descended testis which is pulled into the suprascrotal position by the cremasteric reflex, which means this is palpable. And to differentiate this from an undescended testis, one has to simply hold the testis and pull it down and hold it in position for a minute or so, by which time the cremasteric muscle gets tired and the testis will remain in place. This is a very good differentiating factor. Regarding the pathogenesis, there is a lot of study on this, but finally, the sum and substance is that it is not well understood. Gonadotropin deficiency in utero, decreased Mullerian inhibiting substance, increased estradiol in the placenta, obstruction in its passage, and so on and so forth. In the intra-abdominal phase, its passage is androgen independent. This transit is mediated by descending, but its passage through the inguinal canal, it begins in the 28th week of gestation. It is a combination of mechanical, hormonal, and neurotransmitter effects. So, which means the mechanical is the abdominal pressure, the need for a patent processus vaginalis, gubernacular regression, and of course, the effect of the androgens, the gonadotropins, the Mullerian inhibiting substance, and the calcitonin gene-related peptide. Absent testis is either agenesis or intrauterine vascular compromise. More commonly, it is a prenatal testicular torsion. Ascending testis is another phenomenon seen where the testis has initially been present in the scrotum in early childhood, but probably becomes tethered and gets pulled up as the child grows. It can occur at any time before puberty. Is there a variation in the incidence of undescended testis? Yes, there is. In India, the incidence is between 3 and 5%, but decreases to around 1% by age 1 year. In Denmark, it is around 9%, whereas in Finland, it is just 2.4%. There are different causes for this, whether it is due to just genetics or environmental factors, endocrine disrupting chemicals, lifestyle factors, and so on. But the risk factor for an undescended testis, the most common is prematurity. Being small for gestational age at birth, and birth weight being less than 2.5 kilos. There are associated conditions. Cryptorchidism generally is an isolated finding, but in conditions where there is bilateral undescended testis, you have a whole host of associated medical problems, endocrine disorders, genetic syndromes, morphological abnormalities. All these are seen, and this is the list of the other conditions I won't go into this because it gets very detailed. But remember that when you see these kind of conditions, you then work on identifying what kind of a condition it is, treat that, and then the orchiopexy is done. Therefore, the focus will be on identifying the kind of disorder rather than going in for orchiopexy straight away. Coming to clinical examination, remember this has to be done with patience and care. It is easy in the infant because there is no resistance and there is compliance. But as the child grows older, it becomes more and more difficult to examine it in detail. You'll have to give a lot of comfort to the child, to the parents, examination, and the examination, can you feel the testis or can you not? If it is in the inguinal canal or intra-abdominal, it may be difficult to elicit this in the clinical setup. Once you identify, check the size, look at the opposite side testis, look at the kind of scrotum, examine the penis, note the size, the meatus, whether there is hypospadias, development of the scrotum, and so on. So all these need to be examined along with all the other clinical conditions that I have mentioned. This is just a diagrammatic representation. The left side is an undescended testis. Here we mark out points 1, 2, and 3 are undescended. 4, 5, and 6 are ectopic testis. That means they have descended but have migrated to another position. 7 is a normally descended testis. Generally, the descent of the testis is complete by 4 months. If you have to have this age correction for it, because if it is premature, then you will have to add the remaining months to this 4 months. If it is not descended by 4 months, it is time to evaluate and move ahead with correction. The left side is more common than the right in its undescent. It is indicated by an empty hypoplastic hemiscrotum. The incidence of the undescended testis is in this order. The maximum number is in the suprascrotal region, followed by the inguinal, and the least is the abdominal position. Overall, 20% of these undescended testes are non-palpable and 10% are bilateral. As I've said, some of these that have descended can move up as an ascending testis. Again, the surgical correction for this has to be done within 6 months of the identification. What happens to testicular growth? Testicular growth will be impaired. If the treatment is initiated early, that is before a year of age, there is a partial catch-up. The earlier the correction is done after diagnosis or having waited till 4 months, the better it is for overall testicular function. What are the complications or associated conditions? Possibilities. One is the inguinal hernia. 90% of undescended testes have an associated inguinal hernia which needs attention. The undescended testis is subject to testicular torsion And it is of importance that we keep this in mind, because if it is a non-palpable testis, invariably the diagnosis is much late and we have lost precious time in salvaging this testis. Because of its position in the groin region and against the pubic bone, it is increasingly vulnerable to testicular trauma. Subfertility and malignant transformations are the most concerning factor in management of the undescended testis. Testicular torsion is 10 times more common in the undescended testis, and as I've said, salvage rate is poor. The other condition is the subfertility. They are known to have germ cell dysfunction. The quality of sperm is of poorer quality. This can be due to genetic, hormonal, or development abnormalities. It could also be because of decreased serum inhibin B and increased FSH concentration. The impact of the undescended testis on fertility can be seen in the testis within 1 year of age. Typically, these are seen when they have testicular biopsies done during orchopexy, have proved these changes within the testis. So there is impaired transformation of gonocytes to the dark type spermatogonia. The germ cell density itself is decreased. And if untreated, spermatogonia are absent in 30 to 40% of these testes by age 2 years. Primary spermatocytes fail to appear, and they are present in only 19% of contralateral testes by age 4 to 5. If in the post-pubertal unilateral abdominal testis, spermatogenesis is absent. So we have seen the impact that the undescended testis has on the fertility. And remember, it doesn't make a difference whether the testis is intra-abdominal or it is in the inguinal canal. The impact of its position on the subfertility is the same. The next is the testicular malignancy. We know that there is an increased risk for developing malignancy, but it is poorly quantified. In the sense, do we know exactly how much? We do not. The risk is increased if the incidence is a bilateral undescended testis. In what we do know is that compared to the general population, it is the risk of development is 4 to 5 times. And children with this undescended testis, 21% of the malignancy develops in the normal testis. The other fact that we need to remember is in the uncorrected undescended testis, the malignancy developed is seminoma in 75% of these testes. In the corrected testes, that is those that have undergone an orchiopexy, it is the non-seminomatous germ cell tumor in most of these testes. It is not that the correction changes the malignancy from seminoma to NSGCT. It just indicates that there is a true decrease in the risk of seminoma once the orchiopexy is conducted. The next is the dealing with the non-palpable testis. Imaging studies have very poor sensitivity and generally are not recommended in the evaluation of an undescended testis. The best way of identifying the testis will be an examination under anesthesia when an intracanalicular testis can actually be pushed out or palpable in the inguinal canal. The next will be an exploratory surgery, typically laparoscopy. It is our general habit to ask for an ultrasound study or an MRI scan or a CT scan. These are not as reliable as performing a laparoscopic study. These are just these are images of a testis that is close to an inguinal ring with all the vascular structures intact. This is a testis in the inguinal canal. This shows a hypoplastic scrotum. This shows an absent vascular and vas going there. This is an ectopic testis. This is a normal spermatic cord going out of the inguinal canal internally. These are the other images of the associated conditions that I spoke about, which will need multidisciplinary evaluation. This is a simplified algorithm for the postgraduates to follow. Phenotypically, male child with a testis that is not in the scrotum. So the first thing is, are the testes palpable? If both testes are palpable, then where is the testis that is not in the scrotum? That is what you have to see. If one testis is not palpable, then you look at, is there an associated hypospadias? If both the testes are not palpable, is it a newborn or is it much older? So we'll look at the first one. Both are palpable. So where is the testis that is not in the scrotum? Inguinal or suprascrotal region. The diagnostic possibilities are that it is a true undescended testis, possibly a retractile testis, or an ectopic testis in the superficial subinguinal pouch. Remember, this differential diagnosis is important. If the infant is less than 4 months, we'll wait. We wait till possible descent into the scrotum. If it does, then the problem is resolved. If it doesn't, urologic evaluation and treatment, ideally between the 4 and 12 months of age. If this infant is more than 4 months of age, it is the same treatment. The next is that it is in an aberrant position, that is an ectopic testis. Again, even if it is out of the inguinal canal, if it is an aberrant position, if the infant is more than 4 months, then surgical repositioning is ideally performed. So remember, this is going to be the recurrent theme, which is the treatment for an undescended testis is surgical repositioning. The next one is one testis is not palpable. Is there associated hypospadias? If there is, then the diagnostic possibilities, mixed gonadal dysgenesis, or a true undescended testis, absent testis, ectopic testis, which will need careful examination. And if it is a mixed gonadal dysgenesis, then prompt referral for multidisciplinary evaluation. If there is no hypospadias, then it is one of these three: surgical exploration and management, ideally between 4 and 12 months of age. The last is neither testis is palpable. Is the infant less than 4 months? That is it a newborn? Again, these differential diagnoses you will have to consider. If it is a true undescended testis or the absent testis, then the urologist will take the next steps of evaluation and treatment. But if it is one of the first two, then the child will have to have multidisciplinary evaluation. If it is not in the first few days of life, then you still must consider a simple viralizing congenital adrenal hypoplasia. Again, evaluation and treatment. I am emphasizing these because the general feeling is a knee-jerk reflex that if it's an undescended testis, I will do an orchiopexy. You must consider all the other possibilities. Is there a role for hormonal evaluation of the infant? Yes, you can do it. Especially, it is considered only when it is bilaterally undescended testis. What will these indicate? That is, in infancy or in an older child? High FSH and LH typically indicate anarchia or severe testicular failure. If it is low, it suggests hypogonadotropic hypogonadism. Some people resort to testosterone and HCG stimulation to see if the testosterone rises, to confirm that there is a testis present that is responding by producing testosterone. Anti-Mullerian hormone and MIS, these are reliable markers for the presence of functioning Sertoli cells. Sertoli cells are crucial for the normal development, male reproductive development. If this is low, then you know that the Sertoli cells are not functioning. 17-OHP and electrolytes are used to screen for congenital adrenal hypoplasia, a condition that can cause ambiguous genitalia and impalpable testis. Therefore, as a consequence of this, is there a role for hormonal therapy in the infant? So far, there has been no proven benefit that hormonal therapy will help in bringing the testis down. Then the next option is surgery. I have said already that the focus is on repositioning the testis. It is advisable that this surgery is undertaken by somebody who is focused on pediatric urology, whether a pediatric surgeon or a pediatric urologist, somebody who has experience in this, because it does take a lot of commitment and expertise to have successful outcomes. All surgery preferably done within the first year of life after 4 months, but certainly before 24 months of age. In the palpable testis, this with no other abnormality, it's a very simple next steps, orchiopexy with a high success rate. Testicular atrophy in this condition is a meager 1.8%. Problems that can happen: reascent of the testis, which means it needs surgery again. An inguinal hernia can happen if it has not been present earlier or has been missed during the initial surgery. And of course, the usual infection and bleeding. The emphasis in all the surgical procedure of orchiopexy is to preserve the vascular supply and minimal handling of the testis. These 2 points can never be overemphasized. Then I'm coming to, so we're talking of orchiopexy for intracanalicula and the suprascrotal testis, and possibly abdominal testis that are close to the internal ring. But there is a subset of patients in whom this testis is high up and in whom the pedicle is very short. We are all familiar with the Fowler-Stephen orchiopexy, which is a two-step orchiopexy. But there is also the Shehata technique, which has been described more than a decade ago. I don't know how many of you are familiar or have seen this surgery. So I've just got a tabular column of this. So what does the Fowler-Stephen do? Ligation or transection of the main testicular artery. This is done without disturbing the vessels to the vas and in the cremastem, because these are the accessory vessels. So care is taken to clip this vessel at a higher level. The next orchiopexy can be done at the same stage or as a second stage 6 to 12 months later. The Shehata technique is a vessel sparing or preserving procedure. In this, the testis is fixed to the anterior abdominal wall about 2.5 centimeters superior and medial to the opposite iliac spine. So in the Fowler-Stephen, the vascularity depends on secondary collateral blood flow. In the Shehata technique, it employs gradual mechanical traction, which is the bowel falling on it, the movement of the bowel. All these will stretch the vessels, and you can do an orchiopexy later. The overall success rate with the latter technique is higher than with the Fowler-Stephens. And even in the Fowler-Stephens, when it is done as a two-stage procedure, the success rate is higher than in one stage. Testicular atrophy rate is significantly lower in the Shehata technique as against the Fowler-Stephens technique. Retraction and reascent also is much less. So we have two procedures, one in which you are able to bring the testis down to the bottom of the scrotum, and the other in which you cannot, and then you apply one of these procedures to bring the testis down. Then the next part, which is still not an uncommon finding in our country, is the adolescent undescended testis. When there is a normal contralateral testis, quite often we are wondering whether we should retain this testis or no. If the testis is unable to be brought down, or if the testis is dysmorphic or very small, then orchidectomy is the best option. If for any reason, I'll come to that later. So what is the basis for this? I'm just presenting two papers. In this study of 31 patients, in which they did orchidectomy in an adult patient, of 31, one had intratubular germ cell neoplasia. There were absent germ cells in 12 and impaired spermatogenesis in 27. In the other, much older paper, of 52 patients who underwent an orchidectomy, the histopathology showed absent germ cells in 69%, normal spermatogenesis in 2, and CIS in 4%, which means that in trying to retain the testis by an orchipexy, you are actually running a risk of having a malignancy come out much earlier. The incidence of this is So this is another small algorithm. A post-pubertal male with undescended testis, palpable. If it is yes, examine for malignancy. If there is no concern of malignancy, if the patient is healthy, less than 50 years, then you can consider orchidectomy. An orchipexy is considered only if the non-descent is bilateral and you want to retain endocrine function. But these patients must be counseled about a much higher malignancy risk and teach self-examination. If the patient is much older, then the guideline is to teach them observation and testicular examination. This is because this is historical that the perioperative morbidity mortality exceeds that of a malignancy after the age 50 years. This no longer holds good because now our anesthesia management, chemotherapy management, all of these have improved a lot. And therefore, if it is a concern of malignancy, not able to bring the testis down to the scrotum, an orchidectomy is the best option. If the testis is not palpable and the patient is older than 50 years, the incidence of having a malignancy after the age of 50 also decreases. So you can consider an MRI and ensure that there is no malignancy. The alternative is diagnostic laparoscopy and orchidectomy if the testis is found. Consider even unilateral orchipexy if it is bilateral non-palpable, so that the incidence risk of malignancy is less, at least with one testis removed. So The sum and substance of this is adult undescended testis, orchidectomy. Don't attempt to bring it down to keep it in a place where it is palpable unless this patient is well educated and informed about self-examination or annual checkup. Orchopexy, as the indication, as I've said, is to retain endocrine function because Leydig cell function is not affected to the same extent as the other parts of testicular function. So, goals of management. Fix a viable undescended testis in the normal scrotal position. That's the goal. If it's a non-viable testis, remove it. The goal is to reduce the risk of infertility and testicular cancer. Does it eliminate this risk? No. Can you reduce the risk? Yes. And this is something that has to be kept in mind because, like several other medical conditions, these patients will have to be on follow-up lifelong. Complete the surgery before 2 years of age. This is a repetition. Imaging. Imaging studies are not the standard at any age, whether in adults or in the infants. Laparoscopy is the best option. Repeating and emphasizing. Orchiopexy does not eliminate malignancy risk. The incidence of the risk of malignancy remains the same as long as the testis is not properly in the scrotum. Orchiopexy decreases the risk of malignancy from a probable 5-fold to 2 to 3-fold. What happens to the testis that has been brought down but has undergone atrophy? It still carries an increased baseline risk for malignancy. This is because there is an intrinsic dysgenesis in the testis, and atrophy by itself is an independent factor for malignancy risk. Please remember this because this is very important. Thank you. I have not shown any videos of surgery. That is something that needs a lot of discussion when it is present. Thank you very much. If there are any questions.
I think you have elaborated everything so well. I think we can go to the next talk. And that also is again on a very interesting talk and on a very important topic of the primary reflux. And we have none other than Dr. Prasanna Venkatesh to give this talk. So Dr. Prasanna, please go ahead. Dr. Venkatesh, you can stop sharing so that
Okay.
Dr. Prasanna can share the screen.
Good evening, everyone. Thank you, Sabnis sir. Thank you, Dr. Amit and Suruchi from IPCA for this opportunity. Let me just share the screen. 1 minute, please. Can you see the screen?
Yes, perfect.
Okay, thank you. So VUR, as we all know, is a very, very vast topic. But over the next 45 minutes, I would like to discuss the current concepts and what has actually changed over the last 15 to 20 years from diagnosis to definitive management. It does seem like a very complex issue to deal with. So hopefully at the end of this talk, the decision making would be a little easier. This statement has been picked up from the recent references, but what it does say is that the management of VUR has probably changed more in the last 2 decades than any other pediatric urological disease. the last line is very important. We have moved from operating on almost everyone to carefully select those who truly benefit. As all of us who are practicing pediatric urology would understand, that the number of ureteric reimplants that we've been doing over the years have actually seen a decline despite the increase in number of patients. So these would be the learning objectives by the end of this session. I will touch upon each of them briefly. So what we should know and care about reflux is that it is just not urine going back into the kidney, but what are the potential damages that it can do due to recurrent febrile UTI, pyelonephritis, scarring, going on to leading to proteinuria, hypertension, CKD, end-stage renal disease, and also potentially for girls and women having problems in pregnancy. So therefore, early diagnosis and prompt treatment with the aim to prevent recurrent infections can interrupt this progression. So it is present in 30 to 50% of the children after a febrile UTI, approximately occurs in 1% of all children, with a sibling prevalence of 30% and an offspring prevalence of 35%. One thing that we should understand is, if we have febrile UTI in infancy and it is due to reflux, most of the damage actually occurs then. So the way we handle infants is a little different from the way that we handle older children with their first UTIs. Historically, this was first described in 1952 by Hutch. By the 1960s, surgeons started doing routine ureteric reimplantation for almost all levels of reflux. The concept of continuous antimicrobial prophylaxis, or CAP, came in the 1980s. 1990s saw a lot of emphasis on the endoscopic treatment. 2014, the River trial came out. I will be discussing on that. But what dramatically changed is from 2023 onwards, now we have enough evidence, though this was always there over the last 10 years. But what do we do and how do we manage following a risk-based, individualized management? So the clinical pearl in this is, we now treat the child. Each child's treatment is different, and we don't go by the standard treatment depending upon the grade of reflux. So that is a very important take-home message. Very briefly on embryology, most of you already know it. But if the ureteric bud develops too cranially, there is a short intramural tunnel, reflux occurs. If the ureteric bud develops too caudally, you will have a long intramural tunnel with obstruction. I mean, just very, very a broad description of this. The normal anti-reflux mechanism, all of us know, there is a passive flap valve with active detrusor support and an oblique intramural tunnel. And the now famous ratio which we all speak about is the ureteric diameter to the tunnel length. The tunnel length to the ureteric diameter should be 5:1, which is the classical teaching. And every ureteric reimplantation, we should try and recreate this to the extent feasible. Easier said than done, especially in dilated ureters. Broadly, though this discussion today is going to be with primary reflux, but you can have primary reflux, which is a short intramural ureter. You can have secondary reflux due to high bladder pressure and outlet obstructions. And then you have another type of reflux, which is even more damaging, which is the intrarenal reflux, where these children are more prone for pyelonephritis and scar formation. Just remember that all these three types of reflux can lead to recurrent UTI, renal scarring, long-term complications. we need to identify what type of reflux the child has, and sometimes it can be a combination of both. The incidence, as we said, is 1%. And if a child has a febrile UTI, it is 30 to 50%. Prenatal hydronephrosis is seen only in 10 to 20% of children, especially those who have higher grades of reflux. We spoke about the sibling risk and offspring risk. There is a small female predominance after infancy and male predominance in the neonatal period. There are some genes that have been associated with this, but at the given moment, there is no need for any routine genetic testing. But in the history, ask about any family history of reflux. Natural history of VUR, spontaneous resolution depends upon multiple factors, but predominantly it is age of the child, age of first presentation, grade, whether it is unilateral or bilateral, whether it is associated with bowel bladder dysfunction, and whether there is presence of duplicated system. The other approximate resolution rates, all of you are well aware, this depends upon the grading. Children have better prognosis when they are diagnosed at a younger age if it is unilateral. At the time of diagnosis after the first febrile UTI, if there are no scars, and you have diagnosed this child with reflux without bowel bladder dysfunction. One of the things that we need to remember now, with better understanding of how the bladder and the bowel, etc., works, is that BBD is one of the strongest predictors of persistence of VUR. This is the classical classification of VUR. We are all well aware of it, but many residents get confused between grade 4 and grade 5. Just remember that loss of papillary impressions is seen in grade 5. If you know that one difference, it becomes a little easier. Remember, as we go ahead with this lecture, you will understand that management should never be based only on reflux grade alone. This is a very, very important factor to take into consideration. You should also always assess bowel bladder dysfunction, age at presentation, does the child have breakthrough UTIs, presence, absence of renal scars, and the differential renal function. This is an important slide where you should understand what is the definition of reflux nephropathy. Otherwise, it is very loosely used. It is permanent renal parenchymal damage resulting from VUR, intrarenal reflux, and febrile urinary tract infection. It's a combination. The mechanism may be congenital dysplasia because some of these children have already dilatation in the prenatal phase itself. The kidneys are not developing very well. With the association of urinary infection after birth, they can have acquired scarring, which will result in reflux nephropathy. Now, once scar formation occurs, healing happens by fibrosis. There is tubular atrophy, interstitial fibrosis, and eventually cortical scarring. So what happens is this, as the child grows up, may result in nephron loss, and depending upon the degree of recurrent UTIs, may eventually end up being CKD. So congenital dysplasia is an important factor because sometimes we see these children with their first UTIs a little older. This is generally due to abnormal ureteric bud development seen predominantly in boys and associated with high-grade reflux. Versus acquired scarring is febrile pyelonephritis, intrarenal reflux, especially with high-pressure voids, and recurrent infections. So the clinical consequences are hypertension, proteinuria, reduced GFR, CKD, ESRD. So a point that I would like to make in this is, please seek early pediatric nephrology consults for children with VUR, because generally as urologists, we tend to concentrate maybe on the surgical aspects and maybe on the UTI, but you should always, especially if the child has scars on DMSA, refer them to your pediatric nephrology colleagues. And we discussed this, not all scars are acquired. Many infants with grade 4, grade 5 reflux are born already with dysplastic kidneys. Now, how do these children present the clinical spectrum? It's a little different in infants and in older children. Infants, it is fever without focus, poor feeding, vomiting, failure to thrive, sometimes neonatal sepsis with a history of prenatal hydronephrosis. In older children, febrile UTI, dysuria, frequency, urgency, abdominal pain, especially if associated with constipation, and flank pain if associated with pyelonephritis. In adolescents, especially those who are not been identified or not been treated adequately, you must measure the blood pressure, check for proteinuria, and sometimes they even have incidental hydronephrosis with a history of childhood fevers which were not evaluated. The classical examination, very important, growth parameters, which tells us about the renal function, blood pressure, presence of a palpable bladder, especially if you're looking at secondary VUR, presence of constipation for BBD, neurological examination to rule out other causes like spina bifida, and check the external genitalia, presence of phimosis, decide on the need for circumcision, etc. But one thing what has changed in the last decade or so, over 20, 30 years ago, is that every child with recurrent febrile UTI deserves evaluation for BBD. This is very important. It has come into all the guidelines now. So this is something that I think we should all be glad that a lot more of us, urologists, pediatric surgeons, pediatric urologists, pediatric nephrologists, even pediatricians are slowly getting aware of bladder and bowel dysfunction, which is BBD. And the definition of this is abnormal lower urinary tract function associated with constipation. They can have different voiding symptoms, but one of the more important things is holding maneuvers. They don't pass urine on a timed basis. They go to school for 6-8 hours and don't pass urine at all, or maybe pass only once. Encopresis is something that is a symptom that we should ask: soiling of undergarments, hard stools, painful defecation, constipation. And we'll be really surprised, because when we ask the parents the history, especially when children are between 4 to 7 years of age, the parents simply don't know whether the child is passing stools every day. And even if the child is passing stools, they have no idea on the consistency of stools. So we will need to guide them to observe and get back to us at the next consult on exactly what's happening. Now, why is BBD important? I think there is no discussion on VUR without completing the discussion on BBD, because children with BBD have more recurrent UTIs. It lowers the spontaneous resolution. There is reduced success after deflux or ureteric reimplantation, and there is higher recurrence and persistence after surgery. Now, how all this has happened, there is enough evidence now, so much so that you need to treat BBD first before considering any form of surgery. It could be deflux, it could be ureteric reimplantation. It is preferable in children with BBD, until you get a reasonable control of the BBD, maybe do a circumcision in boys and then put the child on antimicrobial prophylaxis until the BBD is better, before you figure out what you want to do. Do not operate for reflux in children with BBD. The evaluation, of course, you can use one of the scoring systems. A bladder diary is definite must, especially after the children are toilet trained. A uroflowmetry can give you a staccato pattern. A EMG may show that the sphincter movement is not coordinated with increased post-void residual on ultrasound. Now, for reflux itself, one of the first imaging techniques which you will use is ultrasound. We are all well aware of it. It broadly tells us the presence of hydroureteronephrosis, any duplication, renal asymmetry, cortical thinning, bladder abnormalities, and increased PVR, which may give an idea, are we dealing with bladder outlet obstruction or BBD itself with dysfunctional voiding. The limitations, we know that it cannot diagnose reflux by itself. Remember, a normal ultrasound does not exclude VUR. You need to think about whether you want to do a top-down approach where you do a DMSA first because there is no hydronephrosis, or you want to do an MCU. So that is a discussion for another time. The VCUG or MCU is the gold standard for identifying reflux. The advantages is that it can grade the reflux. You can check about the outflow. You can look at the bladder. And the indications would be febrile UTI recurrent, high-grade hydroureteronephrosis, especially in the prenatal period, any abnormal ultrasound, suspicion of posterior urethral valve, suspicion of duplicated systems. In all these conditions, you definitely need to do a MCU. You can do it either by the sterile catheterization technique. We do most of our MCUs using the suprapubic technique so that we don't require to catheterize the bladder. And then most of the residents would have anyway done these MCUs. But remember, especially when dealing with VUR, you fill the bladder adequately. Don't overfill, don't underfill. Make sure that you get good voiding films, and you may need to do it once or twice to get proper images, and take some images both during the filling phase and the voiding phase. This is something that all of us are very familiar with. I wouldn't go into the detail, but as I said, you confuse grade 4 and grade 5. The differentiating feature in grade 5 is loss of papillary impressions. The next step would be to do a DMSA scan. This is the best investigation for renal cortical scars. It gives us the differential renal function. In a setting of acute pyelonephritis, if you have a photopenic area, the diagnosis is generally confirmed, but you don't know whether that will recover or not. And if you delay another scan after 4 to 6 months, if there is a permanent cortical scar, that means that kidney has already been scarred. The biggest advantage is it is very, very sensitive for scars. DMSA may not be required in every child with reflux, especially with low-grade reflux, but anyone having high-grade reflux, grade 3, grade 4, grade 5, and anyone having kidney size discrepancies on ultrasound or due to secondary VUR, a DMSA is a must. Just a note on radionuclide cystography. It's a very good test if you want to follow up as compared to MCU because the amount of radiation is lower. But the limitation is you cannot grade accurately and the urethra is not visualized. What is coming up in Europe is the contrast enhanced voiding urosonography, what is called as CVUS. The advantage is there is no radiation, there is excellent sensitivity, it is repeatable, and it's quite ideal for follow-up if you want to screen these children after a year or two to figure out whether the reflux has actually resolved. But currently it is operator dependent, limited availability. I think going forward in the next few years, it will slowly replace VCUG for follow-up. So which imaging should you order? It depends on multiple factors, but definitely ultrasound is a must. VCUG, if all those indications which I mentioned earlier, DMSA to check on scars. You could try a contrast enhanced voiding urosonogram for follow-up, and radionuclide cystography for follow-up. All investigations need not be done on all children. You need to pick and choose. The evaluation should be tailored to that particular child. The current guideline recommendations for diagnostic workup, the major guidelines, what I've taken, the EAU, AUA, and NICE, ultrasound is a must. VCUG and DMSA in selected children. And of course, CAP is continuous antimicrobial prophylaxis. You don't give CAP in all children with VUR. You do a risk-based assessment and then decide. So there are two concepts in continuous antimicrobial prophylaxis that's changed. One is on whom do you start, and the second is how long do you give. So once you've removed a lot of risk factors in 3 to 6 months and gotten control, you can actually stop the CAP. We will be discussing about it a little more later. Now, coming to the more important slides, what has changed? What is the current philosophy? Please remember that modern management of VUR is risk-based, not depending upon the grade of reflux. So this is the major change which all of you need to understand. How do you assess the risk factor? It depends upon the age, boy or girl, the grade of the reflux, presence absence of BBD, presence absence of febrile UTIs, presence absence of scars. Has it affected the differential function? And compliance to follow-up, compliance to antimicrobial prophylaxis. So please understand a very important message. The decision to intervene, what I mean is surgically, is driven by the child's overall risk profile, not by the VCUG grade alone. So this is a very significant change. Otherwise, earlier it used to be you wait for 3-4 years. If grade 4, grade 5 persists, you operate. So that there has been a change now. So this risk stratification is the foundation of modern VUR management. It is broadly divided into low risk, which you can see in the green here at the bottom of the pyramid. So low risk features are grade 1, 2, no scars, toilet trained child, no BBD, single febrile UTI, normal kidneys. High risk features, grade 4, grade 5, bilateral, recurrent febrile UTIs, renal scarring, BBD, infants less than 1 year, solitary kidney, reduced differential renal function, poor compliance with follow-up. Now, the point in this is that every child need not have all, but they may have a combination of few. So therefore, you need to tailor the treatment to each individual child. A grade 3 reflux in a child with BBD is often higher risk than a grade 4 reflux in a compliant infant without infections. So spend a little more time understanding this, and then at every follow-up, jot down these points so that you can decide ultimately what you want to do for this particular child. A whole lot of children now with vesico-ureteric reflux, as compared to 15-20 years ago, are being observed. It is active surveillance. It is not doing nothing. So the suitable candidates, I have given the list here, but predominantly it is low-grade reflux, older children, no scars, normal renal function, no BBD, a reliable family. And the follow-up includes, apart from everything else that we spoke about, check on the growth, check on the blood pressure, urine analysis to look for infection and protein loss, ultrasound, repeat VCUG only if indicated. Otherwise, you don't need to keep repeating the VCUG every year or every 2 years to figure out what's happening to the grade 1 or grade 2 reflux. You will do VCUG if you think that the child may end up being a surgical candidate. Otherwise, you don't need to expose the child to radiation, and all of us do know that VCUGs are quite difficult tests to do both for the child and for the family. So the advantage of active surveillance is it avoids over treatment, And over a period of time, we know that there is good spontaneous resolution in many children with reflux, especially with the absence of BBD, and the associated surgical morbidity is not there. The disadvantage, of course, the family and the child, they have to be compliant for follow-up. And there is always a small risk of breakthrough infection. But observation may not be appropriate for children with repeated febrile pyelonephritis. If they do have that, strongly suspect BBD and evaluate in that angle. Now, why CAP? The intention is to prevent febrile UTI while waiting for spontaneous resolution. We all know what are the common drugs. But what has again changed in CAP is that you don't need to give CAP for all children with reflux, point one. You don't need to give CAP for a period of 3 to 4 years, point two. You can start CAP until you come to a definitive diagnosis, especially when you see them in the neonatal period with the first febrile episode. And then you do your MCU, you identify whether there is reflux, whether it is a duplicated system, etc. Maybe you will add on a circumcision. And once you get control of multiple things, the child is not constipated, and you should be able to stop CAP in a majority of children within 4 to 6 months. Extremely important. In older children who present with their first UTI and VUR with BBD, maybe you need to put them on CAP till the BBD is better. Once you have reasonable control on BBD, documented by bladder diary, uroflowmetry, checking for constipation, resolution, etc., you should stop CAP. Most children, if identified and treated well, we should be able to stop CAP in 4 to 6 months. We shouldn't be giving them CAP for a protracted period of time, because we all understand the issue of antibiotic resistance, change in the gut flora, etc., etc. So we did speak about the indications in infants with high-grade reflux, recurrent febrile UTI, BBD, and we all know what the problems are. Remember that CAP reduces infections, but not the reflux itself. This is the famous RIVER trial. It is quoted very often and many times asked in the exam also. But broadly, CAP gives the greatest benefit in children with BBD, high-grade reflux, and multiple previous UTIs. There is no significant reduction in new renal scars. And there were certain limitations to the trial. Compliant families, girls, few grade 5 patients. But the bottom line is that you need to select which are the children where CAP will definitely help. There are other landmark trials, which is again constantly quoted, which is the Swedish reflux trial. The key finding was girls with grade 3-4 reflux benefited from intervention. The QT study was the RIVER ancillary study, demonstrated that UTI itself contributes to renal scarring even in the absence of reflux. And the PREVENT trial, low-dose antibiotic prophylaxis reduced recurrent UTIs in predisposed or high-risk children with the VUR. The clinical message is what is most important. Evidence now supports individualized therapy, not routine surgery or routine CAP for all. So that's a very important point and a takeaway. BBD, cannot stress enough. You need to manage them very well. Treat BBD first. If things settle down, you don't require surgery. If things don't settle down in the presence of high-grade VUR with scars, you may still consider surgery, but only after giving the child 3 months, 6 months, 9 months, 1 year proper treatment of BBD. It's a combination of behavioral therapy, timed voiding, treat the constipation, plus minus medical therapy. And some of these children may require biofeedback also. BBD itself is a topic for separate discussion. But broadly, if you have identified a child with BBD, with VUR, do not operate. So that's the message. When I mean operate, don't do deflux, don't do open surgery, don't do robotic surgery, don't do anything until you control the BBD first. Reassess, give the child some time, and then time will tell you whether this particular child actually requires surgery. So because when you treat BBD, because of the reduction in bladder pressures, there is usually spontaneous reflux resolution. It reduces recurrent UTIs. And even if you decide to operate, the success rates are much higher. Do not inject deflux into a child with untreated severe dysfunctional voiding. We'll be burning our fingers. So you should be very, very careful with this. So what is the definition of breakthrough UTI? The definition is febrile UTI despite appropriate continuous antimicrobial prophylaxis, despite good compliance. The causes could be again BBD, incorrect dosing, high-grade reflux, poor compliance, voiding dysfunction, or resistant organism. So you need to identify. Of course, if the child has breakthrough UTI, you need to treat that. And then you need to identify why did the child have breakthrough UTI. You need to address the cause. Otherwise, you'll end up treating only the effect. And the evaluation is very standard. But even if you want to change the cap, don't keep jumping from one antibiotic to the other antibiotic without identifying the underlying cause. The underlying cause will be one of these 6 which I have mentioned on the right side. Now, when should we intervene? There are certain absolute indications and there are certain relative indications. What do I mean by intervention? It could be injection therapy, it could be surgery. Surgery could be open, laparoscopic, or robotic. We're not discussing that. But absolute indications are despite doing everything, recurrent febrile breakthrough UTIs, not having BBD, you've taken care of the prepuce, you've done circumcision, progressive renal scarring, declining renal function, persistent high-grade reflux, maybe poor compliance to CAP or distance to the hospital, solitary kidney. Relative indications are persistent grade 4, grade 5 VUR beyond the expected resolution years, preference of family, and sometimes parental anxiety. The decision should be, you need to put them into whether they are in low risk or high risk by taking into consideration all the factors that we spoke, and on ascertaining that they are high risk, put them onto CAP, and then at some point of time you may need to decide whether you want to do endoscopic injection or surgery. One very important point is that I think parents should play an active role in deciding on the treatment for their children. But of course, you need to spend enough time to counsel the parents, and preferable to take a shared decision making. They should understand the pros and cons of each, because the number of children that we are operating has actually decreased, and there are very, very specific indications when you will operate on the child. So some of the common questions which the parents ask, will my child outgrow reflux? Unlikely after they cross 4 to 5 years of age. But does it require surgery is a question. Low grade reflux, you don't need to do. High grade reflux, if they fall into the high risk category, you'll need to do. Will the kidneys recover? If it is an acute scar, yes. No pyelonephritis for the last 6 months, you do a DMSA, then what will happen is whatever the function is the DMSA is showing is what it will remain. Can reflux recur after spontaneous resolution? If the child develops dysfunctional voiding later, say you do an MCU at 4, 5, it's resolved, but the child already had reflux at 2 years and 3 years of age, they can again get it back at 6, 7 if they have dysfunctional voiding. Is antibiotic prophylaxis safe? Honest question, no one knows. Nobody has done trials for 5-6 years and then checked them 30-40 years later. So we need to communicate all this evidence clearly. That is why I am saying that the duration of cap should come down significantly to 4 to 6 months. This is the classical contemporary management algorithm. We spoke about it: low risk, observation plus minus cap; intermediate risk, if the child has BBD, treat that, and then maybe consider endoscopic injection. High risk, then you can consider a proper reimplant, either open, laparoscopic, or robotic. So the aim is not to eliminate reflux, it is to prevent renal damage while minimizing unnecessary intervention. So if you look, all of these are very, very recent guidelines. I'll just repeat it. Just because you're going to do surgery, it doesn't mean that you're going to prevent renal damage. You need to take care of BBD, you need to lower the bladder pressures, you need to prevent recurrent UTIs. That is what is going to help you preserve the kidneys, and that is the eventual aim of treatment for children with VUR. Just a very brief on the endoscopic management. It was popularized by Puri and O'Donnell from 1984. It is to create a submucosal mound beneath the ureteric orifice to increase the coaptation. And the advantages are it's usually a daycare procedure, no incision, minimal pain, rapid recovery. The disadvantages, it has a little lower success than open surgery, and repeat injections may be required. You have different techniques. You have the sting, the hit, and the double hit. Wouldn't get into the details. All of this information is available. Overall, if you look, grade 1 and grade 2 success rates are very high, but these are a subset of children who probably didn't need it anyway. Grade 3 is around 78%, and as you grow up on the higher grades, the percentage of success comes down. And of course, the factors reducing success, especially in the 80s and the 90s, when probably a lot of children also had BBD, and deflux was injected into all types of reflux, including secondary VUR. So now I think we have much better knowledge, and the best candidates are probably grade 2, grade 3 with recurrent febrile UTI and normal bladder function and no BBD. Failed deflux, you can try it once again, or you can operate. That is a surgeon's choice. Open ureteric reimplantation is the gold standard. It has got an excellent success rate, greater than 95%. You can choose which technique you are comfortable with, how you have been trained, but as residents, you should know all the techniques. It's extremely important. The standard 3-4 techniques you may be asked, and it is critical to know what are the differences. We would not get into those details. It could be extravesical or intravesical reimplants. Now, with the advent of laparoscopy and robotic, there has been renewed interest in especially the robotic assisted ureteric reimplants because of the obvious advantages. But the challenge could be lesser abdominal space, longer operating time, higher cost. Success rates are similar. The technique should be similar to what you're doing in open reimplants. So that's about it. These are the different port positions. And again, you could do Leadbetter Polytino, you could do Leach Gregor. It depends on how comfortable you are doing what. Anyway, that is not the point of today's discussion. But broadly, whether you're doing laparoscopic surgery or robotic surgery, it should reproduce the open surgical principles. It does not change any of the principles. So the best operation, I think you need to decide in your own hand, is the one that offers the highest chance of preventing future renal injury with the least morbidity for that specific child. So there is no one single operation that is better than the other. It depends upon your exposure, your training, what works in your hands. Please do that. Whether it is open, intravesical, extravesical, whether it is laparoscopic, whether it is robotic, it doesn't matter. But as residents, you should know the classical 3, 4 different types of ureteric reimplants and what are the salient steps. Long-term outcomes of vesicoureteric reflux is something that you need to be careful about, especially depending upon the age at which the child had the first febrile UTI. We did speak about all of this, but one point which I would definitely like to make: just because reflux resolves, do not stop follow-up. These children, as they become adults, adolescents, and adults, as they grow up, they require follow-up at least once a year. You need to check their blood pressure. They will definitely have some scars. Check renal function, check for proteinuria. And during pregnancy, they have an increased risk of probable UTIs or developing renal failure, depending upon the scarring. These things definitely require to be counseled. So again, one more change, especially in the EAU now, is that children who have been diagnosed with reflux in childhood require lifelong care, regular follow-up, and early management of UTIs to protect the renal health. You need to continue to follow them up much beyond the usual time period. So when you see children reflux has resolved, don't tell them not to come for follow-up. They should come at least yearly once. There are certain few controversies. This is just to incite thoughts. I think each of these questions is a topic of debate. That is what makes reflux so much interesting to actually identify and treat. But some of these questions: does every child require VCUG after the first febrile UTI? Yes. Should every infant receive CAP? No. Is deflux overused? Earlier, yes. Now, not so much. Can contrast enhanced voiding urosonogram replace VCUG? Yes, for follow-up. Robotic surgery cost effective? Debatable. Should asymptomatic grade 3 reflux be treated, means surgically? No. When should follow-up VCUG be repeated? Only if you're considering any interventions or the child has symptoms. But broadly, management for this condition should be individualized, and a risk-based approach is superior to grade-based treatment. Some of these controversies are there. The first one, that low grade does not cause renal damage. It can cause, especially with BBD. All children with VUR need prophylactic antibiotics. We discussed this. No. Endoscopic injection, success rates are 70 to 80%. Surgery, definitely yes. Which type of surgery doesn't matter. CAP prevents recurrence completely. It only reduces UTIs, doesn't eliminate them. VUR resolves spontaneously in most children. It is possible with low grade reflux, decreases with increasing grade and age. DMSA scan is definitely useful in selected cases, but in our country, it's not very expensive, so better to get it done. BBD we spoke about, it's a very strong risk factor. Once reflux is corrected, risk of kidney damage is gone. We spoke about this. Existing scars can progress, requires long-term follow-up. All recurrences after endoscopic injection require surgery. Many can be managed with repeat injections. We spoke about that also. So remember, VUR is a spectrum of a disease. What one child has doesn't mean that the other child has. And this table I picked up from the recent systemic reviews 2023-25 from the EAU and the AUA. Yeah. So thank you very much. So I'll just stop sharing the screen. Any questions?
Thank you. Thank you very much, Prasanna. I think this was one of the best lectures on VUR that I have ever heard. And I think it's given so much clarity, particularly emphasizing the parent counseling and particularly follow-up in life is so important. They're a special group. I mean, the message is that you can so much cure VR, but you must be wary all throughout your life because it has problems. I think it was wonderful. I think it was so exhaustive. I don't think there should be any questions, but is there any? I can't see anything in the chat box. Suruchi, is there any?
No, sir. No, sir.
Not yet. Wonderful two presentations. Really, thank you very much. Actually, I learned a lot more than the students. But I haven't met you, Prasanna. This was a damn good addition to our list of faculties in the Eurovidya spectrum. You can expect more in years to come.
Sure.
I
sure.
hope the examinee batch has clarified a lot of doubts in their minds. Thank you very much for this exhaustive lecture today.
Yeah, thank you.
Thank
Thank
you.
you, everyone.
Thank you, Ipka, once again. Keep up the good spirit and chase up the people who don't understand what is important for them, particularly for the exam. It is extremely important. They are quite juvenile in my mind, but you need to be very careful about exams. And this sort of lecture is a warning as to where the pitfalls are. Just before closing, Prasanna, can I ask you, in your practice in India or your practice or pediatric practice, do you see a shift in detection from higher grade to lower grade?
Yes, because now what's happening is I think pediatricians are also aware, and most of them at least ask for an ultrasound. And if the ultrasound is showing hydroelectronephrosis, most of them get a MCU, and many of them nowadays come to us with an MCU. So there is reasonable awareness on that.
Who recommends the MCU?
Nowadays, I'm seeing pediatricians themselves recommending an MCU, especially if they see dilatation in the ultrasound.
Yeah, I think that will prompt them. So has that made a shift in your practice? Do you think you're getting earlier patients? No.
Yes, we're getting earlier patients. Yeah, that's
because
true.
we in adults in prostate cancer, we have definitely seen a shift.
No, even for us. The other thing, Dr. Amit, is that prenatal hydronephrosis.
Yeah.
So especially where we are in Bangalore, I think maybe 95-97% of the mothers.
But that's a different ball game altogether. But I'm talking of rural India. That Bangalore and Mumbai and Pune and Delhi, etc. They are different. That's a different logic and a different educational spectrum altogether. But anyway, somebody has asked, Suruchi, to everyone, how to understand severity of the bowel dysfunction in an X-ray.
Yeah, so a simple X-ray KUB, you can actually pick up loaded bowel. You will actually be able to see, despite the child passing stools that day or not passing stools, you will see a lot of fecal loading in the rectum. And many times you will see the entire large colon very much depicted. So that's a simple tool. You can also use the Bristol stool scale. Just give them a print. Many parents wouldn't even have seen what type of stools the child is passing. Tell them to come back in a week and then take it from there.
No, I think the stronger message is you should go for ultrasound nowadays and not talk about X-rays.
Yes.
I think we've shifted our goalposts too much.
No, this is for bowel loading. For bowel loading.
I know, I understand that, but you see, we shouldn't restrict ourselves. There are other methods of assessing them. Thank you. Anything else, Suruchi?
No.
Okay. Thank you all very much to both of you. Dr. Venkatesh Krishnamurthy has left, I think, but I think wonderful. Thank you very much again. And on behalf of IPCA, I will thank you particularly and all the students for your patience. Thank you.
Thank you. Bye-bye.
Bye-bye. Good night.
Thank you, IPCA.
Thank you.